Thank you so much for having me today. My name is Rachael Lopez, and I am part of the surgical oncology team at the National Institutes of Health. My job title is a clinical research dietitian, but a better description of what I do is to help people learn how to eat and how to get the right nutrition when they are missing part of their gastrointestinal or GI tract. So today I'm going to be talking about nutrition after a gastrectomy, or more simply put, eating without a stomach. I have nothing to disclose. If I had to summarize my entire talk today in one slide, it would be this one. As many in the audience today have experienced, for people with a diagnosis of stomach cancer, it can be hard to eat. It can be hard to digest comfortably. It can be hard to absorb micronutrients, such as vitamins and minerals, and it can be hard to maintain weight. After a partial, and especially after a total gastrectomy, it is harder to eat. It is harder to digest comfortably. It is harder to absorb micronutrients, again, meaning your vitamins and minerals, and it's harder to maintain weight. The post-gastrectomy diet is an eating plan and really a lifestyle to meet nutrition needs after a gastrectomy. But the post-gastrectomy diet is a very different way of eating for most adults. So for those who are preparing for or recovering from a gastrectomy, a registered dietitian who has experience with a post-gastrectomy diet can teach you how to eat and how to get the right nutrition without a stomach, and is therefore an integral part of your healthcare team. So in our time together today, I want to start by defining what healthy eating means for those who are living without a stomach. We will then discuss the post-gastrectomy diet and lifestyle, the short-term and long-term nutrition concerns after gastrectomy, and how to manage those concerns. And I will conclude with giving some resources and references for evidence-based diet and nutrition information specific for those living without a stomach. So let's start by talking about the meaning of healthy eating. As a dietitian, I'll be the first to acknowledge that nutrition advice is everywhere. However, there's no one definition of a healthy diet or healthy eating. Your friends, your family, your colleagues, and especially Google may tell you that healthy eating means no simple carbs or no processed foods, only drinking water, no high-fat foods, no high-calorie foods, no mindless eating, eat only when you're hungry. But as many of those joining us today likely have experienced, when someone has cancer, your friends, your family, your colleagues, and definitely Google suddenly have very different and often confusing recommendations for your diet and nutrition. You may hear no carbs, eat a keto diet, no meat, no dairy, follow a vegan diet, no cooked food, eat a raw diet, no sugar, no gluten. There are a lot of no's here. So what is left to eat? Instead of listing all the foods not to eat, let's instead ask what a healthy diet should do for our bodies. A healthy diet makes you feel energized. It allows you to maintain a healthy weight for your frame. It allows you to maintain your lean body mass, meaning your muscle mass and your bone density. And it provides the right amount of nutrients, your calories, your protein, but also your vitamins and minerals for your body. In the setting of gastric cancer, a healthy diet also supports your recovery after treatment or surgery, prevents unhealthy weight loss, and is again tailored to your nutrition needs. So the take-home message here is that nutrition is not one size fits all. Nutrition needs differ from person to person, and nutrition needs change based on age, lifestyle, and certainly after a diagnosis such as gastric cancer when it is hard to eat. Therefore, the definition of healthy eating needs to be individualized based on treatment course, weight trends, if there are any food allergies or intolerances, any GI symptoms, and individualized even further excuse me, when there is a change in GI function, such as after a gastrectomy. Furthermore, nutrition is not just about food, it is about eating, and eating is complicated. We eat for reasons other than hunger, and the foods that we eat are not usually prescribed for us. We choose food based on cultural norms and family traditions. We use food as part of celebrations. We make food for others to show that we care. An experienced dietitian will consider these factors when developing an eating plan that an individual can adhere to before, during, and after treatment, as well as after a gastrectomy. A dietitian should also be working with a multidisciplinary team, including mental health professionals, who can help find a new normal for eating after gastrectomy. Stay tuned for the presentation by Amanda Rhodes later today. She's a phenomenal clinical psychologist who I collaborate with frequently, and she will be speaking about some of these topics during her talk. So when we look at the nutrition guidelines to meet these goals, meaning to have a healthy diet for a healthy weight and to get the vitamins and minerals we need that are specific to an individual's needs, the diet recommendations look very different for the general population compared to someone who is living without a stomach. For the general population, nutrition recommendations are focused on avoiding excess nutrition. When it is easy to eat, it's easy to overeat. So that means needing to balance high-calorie foods with lower-calorie foods to achieve a healthy weight. It also means eating a large variety of fruit and vegetables and whole grains, getting at least 25 to 30 grams of fiber every day, and eating only when hungry to avoid overeating. But after a gastrectomy, the nutrition recommendations are focused on avoiding undernutrition or malnutrition. In this case, choosing high-calorie, high-protein foods when it's harder to eat and intake is low, because we need those high-calorie foods to maintain a healthy weight. It also means choosing foods that are well tolerated, and that can often mean avoiding high-fiber foods if someone's having poor appetite, early satiety, which means feeling full quickly, abdominal cramping, or diarrhea. It also means eating on a schedule, even if you don't feel hungry, and using supplements to meet certain micronutrient needs, again, your vitamins and your minerals. For both groups, however, supplements should not be used to prevent or to treat cancer. Before we get into the details about the post-gastrectomy diet, I want to pause for a minute and clarify recommendations for micronutrient supplementation. So, as recommended by the American Institute for Cancer Research, the American Cancer Society, and the NIH Office of Dietary Supplements, supplements should not be used to prevent or treat cancer. It is important to be cautious with supplements because supplements are not regulated like medications. They can interfere with specific prescription medications and with cancer treatment. They can also cause other complications. So it's very important to discuss all supplements with your physician, your oncologist, and your dietitian. And when supplements are needed, make sure that you're choosing brands that are third-party tested for accuracy and brands that follow good manufacturing processes. But dietary supplements are necessary in certain situations. For example, to treat a vitamin or a mineral deficiency, such as a vitamin D deficiency, to prevent deficiencies for specific diagnoses, such as pernicious anemia, and to prevent deficiencies after specific surgeries, for example, a total gastrectomy. So let's transition now to talk about that last scenario, a gastrectomy, for which very specific dietary supplements are necessary. To understand how to eat and how to get the right nutrition without a stomach, it's first helpful to review the functions of the stomach. The stomach sends hunger signals to the brain to remind you and to tell you when it's time to eat. It can hold a large quantity of food, It's very elastic and expands after a meal. It can hold more than a liter of food and fluid. The stomach holds food until it's ready to be absorbed in the intestine. The stomach also prepares food for absorption mechanically by grinding food into a puree. It's basically a blender in your body, and also chemically by mixing food with digestive enzymes and stomach acid. The stomach also controls how quickly food moves into the small intestine, which is ideal because the intestine needs time in order to absorb the nutrition that you eat. So eating without a stomach means the loss of the normal hunger cues. This can cause anorexia, meaning the absence of hunger or appetite, for 12 to 6 months or even longer after a gastrectomy. As a result, people need to eat on a schedule even though they don't feel hungry, because they can't rely on their body to tell them when it's time to eat. Without a stomach to hold large quantities of food, people also need to eat small meals, but more frequently, because they feel full very quickly. The diet also needs to be adjusted based on what is eaten and when it's eaten, and when to eat and when to drink, to prevent something called dumping syndrome, which we'll talk about in the next few slides. Since the stomach is no longer available to break down food for absorption, the teeth take on that very important role, meaning people need to chew every bite of food very thoroughly so that the food can be comfortably digested and absorbed. This also means that people don't absorb all of the vitamins and minerals from food alone, and that specific vitamin and mineral supplements are needed to prevent deficiencies. And then finally, without the usual control of how quickly food moves into the small intestines, the diet needs to be adjusted to prevent dumping syndrome. So let's break this down into the details of the post-gastrectomy diet and lifestyle. Again, without the normal hunger signals, it's important to eat on a schedule, not to wait until you feel hungry. It's also important to eat very frequently, because without a stomach, you would feel full very quickly. Immediately after a total gastrectomy, an appropriate meal size would be about 2 to 4 ounces of food total, which is 1/4 cup to 1/2 cup of food total per meal. In order for adults to get enough calories and protein with such small portions, they need to eat very frequently, at least every 2 hours during the day. So here is an example of a daily schedule with these small but very frequent meals every 2 hours. You may notice that many of the calories and much of the protein come from protein powders and protein drinks, because using these products adds a lot of calories and protein in a small volume. You can also see that solid food is separated from fluids. Fluids cause people to feel full even more quickly, so separating the fluids from the solids helps people be able to eat more at each meal. Fluids also help the intestine contract and therefore move food more quickly through the GI system. We don't want food to move through too quickly because the intestine needs time to absorb it. So separating fluids from solids helps the intestine be able to absorb more, and again, prevent something called dumping syndrome. So there are actually 2 forms of dumping syndrome: early dumping syndrome and late dumping syndrome. When most people use the phrase dumping syndrome, they are referring to the early form, which is a reaction to a rapid release of highly concentrated food or fluid into the small intestine. This happens soon after a meal, usually within 15 minutes to an hour, and symptoms can include sudden onset diarrhea, nausea, cramping, flushing, heart palpitations, and low blood pressure. These symptoms mean the food is passing through without being absorbed. As a result, people can develop food aversions and even a fear of eating when they experience these symptoms right after eating. They can also lose weight too quickly because they're not absorbing what they're eating. Strategies to prevent early dumping syndrome include eating those small meals, but very often during the day, chewing food very thoroughly to help it be absorbed, again, separating solid foods from fluids, eating protein with every meal, and avoiding added sugars, meaning pure sugar that is added as an ingredient, such as cane sugar, high fructose corn syrup, honey, brown sugar, other syrups, agave, and so on. Because added sugars are highly concentrated and they draw more fluid into the small intestine. So it's very similar to eating and drinking at the same time. When someone is eating food or a drink with added sugar, it draws more fluid into the intestine, which results in those GI symptoms. The second form of dumping syndrome is called late dumping syndrome. Late dumping happens anywhere from 1 to 3 hours after eating. It happens as a result of a quick rise in blood sugar, which causes the pancreas to release a lot of insulin, resulting in a blood sugar crash or a low blood sugar. This process is not due to diabetes. In this case, blood sugar rises more quickly after a gastrectomy because food goes straight into the small intestine, whereas before, the stomach would only release food into the small intestine a little at a time. The symptoms of late dumping syndrome are symptoms of hypoglycemia or low blood sugar. They include things like double vision, lightheadedness, heart palpitations, sudden confusion or anxiety, hot flashes, tremors, feeling faint, or sudden irritability. Strategies to prevent late dumping syndrome include eating small meals frequently throughout the day, chewing food very thoroughly, again to help it be absorbed, eating protein whenever eating carbohydrates, and avoiding added sugars. So many people are able to identify sources of added sugars in what I call predictable sources: your desserts, your candy, syrups, sodas, and other sugar-sweetened drinks. But there are also many hidden sources of added sugars in foods that are not necessarily sweet. Things like yogurt, ketchup, sauces and marinades, salad dressings, granola bars and breakfast cereals, traditional protein drinks such as Ensure and Boost, and many meals eaten outside of the home, such as restaurant meals. Shown here is a nutrition facts label for a yogurt. You'll see that there are 10 grams of added sugar in this yogurt, which would cause early and/or late dumping syndrome after a gastrectomy. Therefore, eating after a gastrectomy requires a close look at nutrition labels to make sure that the ingredients will not cause dumping syndrome. So far, in terms of the post-gastrectomy diet and lifestyle, we've talked about eating on a schedule, and that means every day, not waiting for hunger cues, eating on that schedule to make sure that you're getting enough calories and protein throughout the day, eating small but frequent meals every day, chewing every bite of food thoroughly before swallowing to help the food be absorbed, to separate fluids from solids every time, to eat protein at every meal and snack, and to avoid added sugars at every meal and snack. The post-gastrectomy diet and lifestyle also means being mindful of physical positioning both during the day and at night, and that's to prevent something called bile reflux. So bile reflux is a burning sensation due to bile that's backing up into the esophagus. It's most often triggered by physical positioning. So to prevent bile reflux, in addition to eating your small meals often and chewing food well so that it's digested comfortably, it's important to remain upright after meals, to sleep with the head of your bed elevated at least 30 degrees to prevent bile reflux overnight, Bending at the knees rather than leaning forward at the waist is also very helpful to prevent bile from coming back up. Avoiding constipation, because pressure lower in the GI tract makes it easier for bile to come back up. And talking to your team about medications if bile reflux continues despite these diet and lifestyle changes. So to review once more, this post-gastrectomy diet and lifestyle means eating on a schedule every day, eating your small, frequent meals every day, chewing every bite thoroughly before swallowing, separating fluids from solids, eating protein at every meal, avoiding added sugars, being mindful of the physical positioning every day and at night, and then finally taking the recommended micronutrient supplements every day. Because after gastrectomy, people are at a high risk of micronutrient deficiencies because without stomach acid and without intrinsic factor, and when part of the small intestine is bypassed, such as a Roux-en-Y reconstruction, certain vitamins and minerals are not well absorbed. Consequences of micronutrient deficiencies include, but are not limited to, anemia, decreased bone density, changes to teeth, skin, hair, and nails, confusion, peripheral neuropathy, meaning a numbness in your fingers or toes, changes to immune function, neurological changes, and fatigue. Specific nutrients of concern include vitamin B12, which many people recognize after gastrectomy, but there are many other micronutrients as well, including thiamine, folic acid, zinc, iron, calcium, and the fat-soluble vitamins A, D, E, and K. Prevention of deficiencies is key and includes lifelong use of specific bariatric formulated multivitamins, which means that the vitamin is formulated in a dose and a form that can be absorbed without stomach acid, without intrinsic factor. Calcium citrate is also needed because it is the form of calcium that can be absorbed without stomach acid. Lifelong monitoring is also needed, and any deficiencies must be treated aggressively to prevent serious consequences. So to summarize, the post-gastrectomy diet is not just an eating plan, it's a lifestyle. It includes eating on a schedule, eating often, chewing very thoroughly, separating fluids from solids, eating protein at every meal and snack, avoiding added sugars at every meal and snack, being careful of physical positioning both day and at night, and taking the recommended micronutrient supplements every day. This is not a diet that has cheat days, because deviation from these guidelines contributes to both short-term and long-term nutrition concerns. Short-term nutrition concerns include GI symptoms, some of which we've already mentioned, such as anorexia, meaning the loss of appetite or hunger, early satiety, meaning feeling full quickly, bile reflux, bloating, abdominal cramping, constipation, or dumping syndrome. Following the post-gastrectomy diet and lifestyle helps manage these symptoms, but a multidisciplinary approach for both the diet and the lifestyle changes and medical management may also be needed. The dose and timing of medications must be tailored for people without a stomach. Preventing GI symptoms prevents food aversions and the fear of eating. I see food aversions and the fear of eating often after gastrectomy when people feel ill after eating because they're eating too quickly, they're not chewing thoroughly enough, or they're eating foods their body is not able to absorb or digest comfortably. Dehydration is another common concern because it is hard to drink enough fluid and eat enough calories day to day. Following the post-gastrectomy diet, again, prevents GI symptoms that would make it even harder to get enough fluids. And following the lifestyle of small but frequent meals, balanced with fluid intake between meals, also helps prevent dehydration. The diet and lifestyle also prevents hypoglycemia or low blood sugar, which can happen from not eating often enough or from late dumping syndrome. All of the diet and lifestyle strategies combined helps prevent people from losing too much weight or losing weight too quickly. Even if someone is overweight before a gastrectomy, rapid, unintentional weight loss, meaning losing weight quickly because someone cannot eat enough, means that someone's losing muscle mass and even bone density, which is not healthy. The risk of losing too much weight, and especially losing muscle mass, is a long-term nutrition concern as well. After a total gastrectomy, it can be very hard to regain significant amounts of weight. Suboptimal absorption and unintentional weight loss also increases the risk of decreased bone density. And as we discussed earlier, changes in absorption also increase the risk of micronutrient deficiencies. So prevention is key and includes taking the right vitamins and taking the calcium citrate, being active when able, and treating deficiencies aggressively if they do arise. While there are significant nutrition concerns, these concerns can be addressed by optimizing nutrition care before and after surgery. Because the post-gastrectomy diet and lifestyle requires significant and lifelong behavior change. These changes start right after the surgery and continue lifelong. These behaviors eventually become new habits, but behavior change takes time and repetition, and this is not a situation where someone can gradually adopt one change at a time after their surgery. This is also not a diet or a lifestyle that people learn in one counseling session. Therefore, the post-op nutrition care really begins pre-op, ideally with diet education well before surgery, and usually over multiple nutrition consultations. Pre-op nutrition consultation is the time to address any pre-op nutrition concerns, such as unintentional weight loss, any diet restrictions, or micronutrient deficiencies, as well as any other relevant issues that directly impact nutrition, such as lack of access to food, needing help at home, any dental concerns, or other concerns such as depression or anxiety. This is the time to engage other members of the multidisciplinary team to really optimize the patient's care. Pre-op nutrition counseling also provides time to start adjusting to the post-gastrectomy diet and lifestyle so that there are fewer changes after the surgery. Post-op nutrition care should also include regular follow-up with a dietitian to evaluate micronutrient and macronutrient needs, help with any GI symptoms, and to evaluate and treat weight loss. But in addition to working with a dietitian, it is essential to communicate with other members of the healthcare team. Our program here at NIH includes a structured follow-up schedule where our team sees patients together in clinic both before and after their gastrectomy to coordinate care for each individual. So how do you find a registered dietitian? Just as you would choose a surgeon and an oncologist who is board certified and experienced, it is important to choose a healthcare professional who is appropriately trained in nutrition. Registered dietitians and registered dietitian nutritionists have specialized training to help you manage your specific nutrition needs. They need to complete a board exam before earning their credentials and must also submit continuing education every 5 years to maintain their credential. There is no standard definition or training for a nutritionist who does not have the RD or RDN credential. To find a registered dietitian near you, ask a member of your healthcare team for a referral, or you can log into the Academy of Nutrition and Dietetics website and hit Find an Expert to search by location and expertise. So in my concluding slide, I again want to emphasize that people who have a gastrectomy have unique nutrition needs. Following the post-gastrectomy diet and lifestyle, meaning not just what you eat, but when you eat and how you eat, helps lower the risk of both short-term and long-term nutrition concerns. The post-gastrectomy diet and lifestyle is not something a person can learn in just one meeting and do for the rest of their life. So to optimize nutrition care before and after surgery, seek nutrition counseling from an experienced registered dietitian as part of your healthcare team. My final few slides have a list of references and resources, as well as my email for questions. Thank you so much for your time.